Hello, everyone. Welcome to Adapting and Supporting Equitable Access to Primary Health and Social Services for People Experiencing Homelessness. This is the second webinar in a mini-series exploring shelters as public health settings. My name is Susie Taylor, and I'm a Knowledge Translation Project Manager at the National Collaborating Center for Infectious Diseases. The NCCID is situated on the ancestral lands of the Anishinaabe, Anishinaabeg, Dakota Oyate, Denesuline, and Nehithiwak Innuwak nations. It's also the homeland of the Métis Nation. We're on Treaty 1 land, and we recognize that this and other treaties have been implemented as part of a process of colonization intended to benefit some while harming others. The effects of colonization can be seen today in different ways, including the disproportionate experiences of houselessness and shelter use by Indigenous peoples. This webinar series has been prompted in part by our reflection on the Truth and Reconciliation Commission's calls to action, particularly 18 and 19, and the calls for justice from the National Inquiry into Missing and Murdered Indigenous Women, particularly 4.1, 4.6, 4.7, 16.19, and 18.25. I'd encourage everyone in attendance to reflect on how these calls for action and justice relate to the topics we discussed today as we work together towards reconciliation. For some housekeeping, we will have time for questions at the end of the presentation. During the presentation, you can pose questions using the Q&A tab, and they'll be moderated at the end. We will respond to as many questions as possible, but we may not be able to get to all of them. I'd now like to introduce our speakers. Sarah Allen is the Associate Professor of Health Policy at the Institute of Health Policy Management and Evaluation at the Dalla Lana School of Public Health at the University of Toronto. She's also the director of the North American Observatory on Health Systems and Policies, a collaborative partnership and research center focused on subnational and international health system research to support evidence-informed policymaking. Monica Rohrig has been working with the NAO as research coordinator since 2019. She holds a Master's of Art degree in community psychology and has contributed to many research projects and evaluations for a wide variety of stakeholders. Welcome, Sarah and Monica. Thank you both for joining us today.
Thanks, Susie, for the invitation. We're really pleased to speak with you all today and share our research and hear your thoughts and questions and suggestions for developing this into further research and policy considerations. And it's a really helpful to have a chance to hear from different perspectives. And so I really look forward to the Q&A component of today. The projects that we're presenting today were funded by Healthcare Excellence Canada and the Ontario Ministry of Health, and they're publicly available. So we'll post the URLs. You can see them in their full form online on the website of the North American Observatory on Health Systems and Policies. Everything's open and available. We can answer any questions today or an email. We don't have any conflicts of interest to declare. But we really are grateful. We couldn't have done this work without many different experts and healthcare and social providers and managers who helped to share insights and reviewed versions of our reports and spoke to us as experts in their own jurisdiction or in their own sort of initiative that they lead. So we are grateful to our funders and to those who supported this work, as well as our research team, who, you know, we rely a lot on team work and collaborations across countries and within countries, and our own team has many trainees, and Monica and I are just two of those who and others are listed here on this slide. So on the next slide, we will hope to leave you with some of these key learnings today. So broadly, we're going to leave you with an understanding of some of the key features of adapted or innovative primary care models in non-traditional settings, that sort of outside of the mainstream kind of primary care practice model, that could help to improve accessibility and appropriateness of care for the population of interest to us for these studies, which is people experiencing homelessness. We're also hoping that you'll leave with some insights into the variety of approaches taken across a variety of countries and in Canada to adapt or innovate in primary care delivery. And we're also sharing some promising practice from within the province of Ontario sharing some of the insights learned from these promising practices in terms of what are the features that may support improved access to health and social supports for people experiencing homelessness. And we'll also leave you with some insight into where future research could really help to fill some of the gaps, and policy attention is really needed to address and continue to support this population that has many complex health and social needs. So on the next slide, just briefly, we're going to share some of the rationale and background for the work. I'm going to turn it over to Monica. She's going to walk through some of the methods and key findings, and then I'll also share some key findings, and then we'll both present some conclusions and takeaways from this work, and we really look forward to Q&A after that. And on the next slide, these are just 4 of the headlines that you can see in news media across the world. Homelessness is a very long-standing, persistent, and extremely challenging problem across, communities, individuals, the health system, all of society. And the problem of homelessness is increasing across Canada and in many other countries. And in our work, we define or kind of consider people experiencing homelessness as those who have no fixed address. They are vulnerably housed, and they collectively often face multiple intersecting challenges around accessing the health and social supports they need, in part due to stigma and exclusion, marginalization, racism, and other institutionalized forms of discrimination affecting this group disproportionately. Although it's important to note that the population experiencing homelessness is highly diverse, and there are many distinct challenges and distinct populations within this group. Even though we call it a single group, it's highly heterogeneous. Although on the whole, there's a significantly higher rate of challenges with both chronic and infectious diseases, mental health challenges, substance use, in general, much higher than the average population. And these challenges are really exacerbated by barriers faced to health and social supports that are needed for this population. On the next slide, we're sharing some data that was recently published by the Canadian Institute for Health Information. And they were able to identify and sort of track hospitalizations among people who are experiencing homelessness. And we recognize this is probably a very underestimate of the magnitude of the challenge because of inability to track necessarily all people who may be vulnerably housed. But in what this data show are the high rates of hospitalization among this population and prolonged stays once people are hospitalized, and some of the key drivers of hospitalization around substance use disorders, mental health, severe mental health problems, and infections. And what this also suggests is that there are people experiencing homelessness are arriving much later at a much more acute stage in illness, in part due to these barriers to receiving care in community and in primary care, and receiving adequate supports socially as well. So generally, we see higher rates of hospitalization, higher frequency of emergency department use, but we also see, population level outcomes like life expectancy being much lower in this population, as well as I mentioned, some of the challenges with mental health, the prevalence of diseases is much higher. And so this the magnitude of this problem cannot be understated. And the work that we did was really trying to, recognizing that we're going to need to address this challenge in multiple ways, both addressing the failures within our mainstream sort of health system and, ensuring that hospitals, primary care clinics, public health units, et cetera, are all well placed to address the needs of this population, but also looking at these non-traditional or kind of alternative approaches that may be needed to ensure that, for people who do fall through the cracks, they receive fragmented care, more sort of preventive interventions and outreach and so on is needed. And so we were interested in looking at that space specifically, and I'll turn it to Monica to walk through the broader aims of this review. And the next slide.
Thank you, Sarah, and welcome everyone. In segueing to the work that we did, really we're presenting findings from two projects, two rapid reviews that we conducted. And thinking about the Canadian context, we've seen that there has been policy attention towards the health and social care needs of this population, but it's been moving at a bit of a slower pace. So with that in mind, we want to understand what local strategies exist and get a sense of the landscape from other jurisdictions. So in the first rapid review specifically, we were aiming to see what are the types and features of primary care models in these, quote, non-traditional settings that might contribute to improved access to primary care for people experiencing homelessness in some of the select high-income countries that we explored. And in the second, was more focused to uncover promising interventions to increase access to health and social services for people experiencing homelessness in Ontario specifically. Next slide. So for both reviews, we conducted a literature review, including academic and gray literature sources like websites, reports, and also spoke with experts. These could include clinicians, researchers, frontline staff, executives, managers. And really that was to help not only identify these promising models or interventions, but also to validate what we were finding in the literature and link to any other additional resources or fill in some gaps that we had. Just press next, please. For the first rapid review, we were focused on primary care and homelessness. We limited this in terms of the years for feasibility and was focused on reports available in English. And we included models that improve access to primary care in high-income countries. So if it didn't measure or specifically say that it improved access, then those were excluded. And notably, we also excluded things that were focused or interventions or models focused exclusively on housing first, and as well that spoke to specific health conditions that were outside of a larger primary care model. And we spoke with 10 experts in January of 2021, which seems like quite a long time ago now, including 6 from Canada, 2 in the US, and 2 in Ireland. And next, the second rapid review was focused, as I mentioned, on Ontario initiatives specifically. And this rapid review was conducted more recently, so our search was a bit more updated there. And we spoke with 11 experts from 7 select initiatives in Ontario. So we had quite a large list of interventions and initiatives and projects happening across the province, but we narrowed it down to really get a better sense of what evaluations exist, what are the outcomes for some of these promising practices, to have it a bit more digestible and also in the interest of our time. I just want to add the limitation disclaimer that these searches don't represent a comprehensive catalog of all the initiatives. So this really was just meant to identify a variety of initiatives that show the breadth of approaches. And although COVID-19 was central to a lot of what we were hearing and learning about, we didn't focus on any initiatives that were solely focused on COVID-19. Next slide. So when we gathered all of this information and looked at all of these different interventions and models, we were really interested in these main things in the figure there about who is the target population and how is care being delivered. Where are these interventions being delivered? So what is the site of the service delivery? What is being provided and how? And when is the service being delivered? So thinking about how things are accessible and looking at that in a framework of access that not only just includes if something's convenient or just available in the hours that you want to, but is it appropriate for somebody? And how is it available to somebody? And in terms of affordability, what are some of the indirect costs that need to be considered for someone to actually access and go to receive care? Next slide. So now we'll transition into some of the key findings. In the interest of time, we present findings across both of our reviews. There were a lot of similarities and overlapping themes. So where possible, we'll try to pull out some examples a little later on. Okay, so first, we uncovered a wide range of initiatives and models, and we grouped these in terms of how someone would access or enter this service in 3 different categories. And that included non-urgent or primary healthcare, social care and services, and urgent self-referral. So the usual access sites were shelters and facilities that serve individuals with substance use disorder. This could also include mobile health or outreach teams and hub and spoke models. And the fewest examples were actually found in the last grouping, the urgent self-referral group, where individuals are connected to supports through urgent or emergency care settings. And we saw examples such as services where someone would be connected in the emergency department so that they would have post-discharge care navigation and care management. And many of the services, particularly in co-located or integrated services in outreach or mobile units, offered a wide range of services as well. Some of these included support navigating the systems, both health and social care, harm reduction supply and support, infectious disease testing, and in some cases treatment, housing support, getting connected to different supports or getting on a sort of like wait list or connection to the actual different systems, and providing basic needs. And in terms of target population, we saw that a lot of them mostly targeted the general sort of population of those experiencing homelessness, but also some were specific to subpopulations. This could be families, youth, based on gender or health condition and needs, and some for Indigenous peoples. And I do note that this was also likely due to our search being quite broad, because again, we were just trying to get a sense of the types of interventions and models that exist. And unsurprisingly, these team compositions and collaboratives included a lot of different agencies and types of organizations and providers. So they were highly multidisciplinary, often included multi-organizations or agencies. And some of the specialized roles that we saw were nurse practitioners, mental health nurses, community health nurses, case managers, treatment coordinators, community health workers, and system navigators. There are also some examples where they included traditional healers and elders. Some also sort of facilitated or run by students and trainees, especially medical students. And finally, peer workers and people with lived experience. And if you just press next, I want to really highlight the impact and role of peer workers and people with lived experience, not only in service delivery, but also in being part of boards of directors and helping to ensure that they're participating in sort of the direction and development of not only the organization, but different programs. And we saw that in a few examples.
Thanks, Monica. I think I'm taking on now. We like to go back and forth. So yeah, Monica presented some of the high level sort of categories that we grouped our findings and tried to compare across the different models and programs that we saw internationally and in Ontario. And one of these cross-cutting themes that really was apparent, across jurisdictions, across models, was this challenge around funding. And notably, all of these initiatives and innovative programs were relying on multiple funding sources, often small grants, often very time-limited funds that came as part of a research program or as part of a short-term grant from government. Government funding did include, the usual sort of health coverage programs in a jurisdiction, but also a huge reliance on non-government. I think that's meant to be non-government or NGO or charitable funding, and then pooling and trying to compile enough funds through multiple agencies that Monica talked about in terms of, each group that being involved would contribute in kind and funding supports for these initiatives, that whether it was to maintain a mobile unit or maintain a community-based, safe consumption site supports or other things, were usually, very precariously funded in the sense that these were not long-term and not sustainable. And then if you press next, I think this really came up in a lot of our consultations covered in the literature, that there was a huge recognition of the importance of supporting people experiencing homelessness during the pandemic. And correspondingly, we saw a huge increase in investment, temporary programs, and often with the aim of reducing transmission of the virus and protecting the population at large. But that often involved, temporary housing of homeless people within hotels and other things in Canada and across jurisdictions. This was seen, and in some cases, this short-term, emphasis and corresponding increase in funds to support these initiatives were used to then support and scale up and make a case for increasing and having a longer-term investment in these programs. So in some cases, for example, in Toronto, there's been some success in maintaining some of the additional pandemic-related investments that were made to continue the programs. But in many others, the programs have had to end, and either initiatives were closed down or relying on different funding sources. And everyone we spoke to really talked about the challenge that came from the lack of sustainable funding and, the program insecurity and not being able to provide these in the long term, challenges with long-term, planning and program operational planning. And then with staff was a huge issue in terms of recruiting and retaining experienced staff, given this context of inadequate funding. And then relying on sharing and in-kind supports as much as needed to compensate for this. So this really was a prominent theme across all of our international and local findings. And in the next slide, I'm going to get into a few of the results we had around how these initiatives are being evaluated. How are they measuring the impacts of these programs and adaptations and non-traditional primary care sites, et cetera, on the sort of different levels of the health system and also population health and individual experiences. And so in the first impact slide, I'm going to share with you some of the health system level impacts that have been noted and covered in some of the studies. So often we see, a big lag in terms of when studies have been implemented and then when evaluations are available. And some of the data we present here are not up to date or not the most recent, but they do show across international examples as well as local that there are some evidence of reduction in hospital use and emergency department use, and the types of healthcare that's avoidable with primary and preventive care. And so in the US, this was exemplified in one telehealth initiative where drop-in centers that offered video consultations within the drop-in center was able to reduce ED visits. Also an example in London CARES where there's counting individuals. There's small population of people being served, but many people being diverted from hospital and emergency services as a result. And then in a local example in Ottawa showed that, tried to put a kind of cost estimate on the health system impacts. And often these are required and requested in order to make a funding budget case for increased funding from the Ministry of Health, for example, to show that these programs are effective in reducing costs in acute care. And so there has been some attempts to measure this and quantify And many other examples are evident in the literature. And I'll just mention one other that sort of struck me as being particularly promising, where a TELUS Health initiative, sort of TELUS Health was sponsoring a mobile clinic in the Niagara region. And this sponsorship allowed the initiative and the users of the mobile clinic to populate an EMR, an electronic medical record system, and to be able to collect information on healthcare use throughout the system. And this allows the program to then monitor healthcare use and see to what extent the mobile clinic is helping to divert users from emergency room and to track health over time. So the next slide shows some of our findings with regard to, I think we just missed one. If you go back one slide, the client and patient level health impacts was another sort of dimension that these studies that were available in the literature and that were shared with us in reports from the expert informants showed that client and patient level health impacts are measured through a variety of ways, often through survey and qualitative studies to show how these programs are helping to address health needs, improve quality of life, and helping to reduce barriers to care. And we've provided, again, a few examples that stood out to us where, one example is, again, in Ottawa, with the trailer, which is a safe consumption space and treatment service that provides wraparound care around primary care, mental health, and substance use. And there were reports of, reducing 1.2 overdoses daily. And now apparently this has been updated. Monica tells me that it's serving at 225 people a day, and the reduction in overdoses has doubled. So these types of metrics are really compelling, showing that the evidence of health impacts are quite striking. And another example is just the ability for these non-traditional, often just highly accessible, low barrier services to be able to maintain and keep people within care and keeping them, accessing the care that they need in a longer term basis. And the retention for treatment is also one of the ways that this is measured. And so in the next slide, we really try to highlight, and this was one of the ways we depicted the results of the first review. And we thought that these, this visual helps us to capture the results from the Ontario work as well. So as we click, we'll sort of walk through some of these. So the first key consideration, and these are like the kind of requirements in terms of ensuring that, health and social care is accessible and available and actually has impact on improving the health of people experiencing homelessness. And one is this, the key factor of ensuring that these supports are fostering positive relationships. And this was seen across all the initiatives that we found internationally and locally, where the relationships were really central to their effectiveness, how to ensure that people would continue to use the services, that would have the positive impacts that we described, was really based on the relationships that they had, that people felt listened to and respected, informal and non-judgmental approach. And the care team were interested in their health, but also their lives, and sort of seeing them as holistic people with many different needs and interests, and not just focusing on a particular health condition or issue at any given point. And so this was essential, the sort of one of the key considerations. And the next key consideration, and Monica touched on this in terms of the diversity of care providers on the teams. So this was seen also to be essential in ensuring that these programs are effective and having impacts, is people who are living with experience or have lived experience with homelessness, with addictions and substance use, whether they're peers or community outreach workers or outreach specialists, and other interprofessional members of the team are needed to address the complex needs of this population. And diversifying the workforce and the care team is really seen to be essential in the delivery of primary and social services, including, nurse practitioners that were highlighted a lot, as well as case managers and peer workers. The third kind of key consideration is around the type of environment and, ensuring that the physical space and the social environment is, open and inclusive and includes safety in terms of cultural safety and personal safety, and that there's, flexible and relaxed kind of hours and less standard than the kind of business day. And there was also many initiatives providing additional supports and sort of activities and both social and sort of, useful sort of, laundry and other types of programming being available to ensure that this is a welcoming and reducing the sort of barriers and stigma associated with accessing care and supports. And so there's three more. Monica's going to share those, I think, and then we'll wrap up.
So the fourth is a support system navigation, build connections to mainstream care to reduce barriers. This really relates to everything that we have been saying already, but reinforcing having help navigating the system, making quick referrals and connections is really important. And having a designated person to not just navigate and coordinate the service, but also more directly advocate for the individual is really important. An example is, having someone accompany a client to a service appointment. This could be a diagnostic test, or just even making sure that they get where they need to go. Even receiving, status of someone's test can be very daunting, and there's a lot of stigma attached to that as well. So sometimes having an advocate, not only to get to that service, but make it through that encounter is critical. And the co-location of services would also help this, especially since issues of housing and income instability might take precedent over other health-related matters. So going back to sort of this laundry service, if someone is already at a place, going to meet where people are is extremely effective means to connect them. The next is enabling collection and sharing of health information to improve care continuity and support evaluation of primary care programs. And although we had one really great example with the TELUS Health and having data, there really is this need that we heard about having more robust data collection to help evaluate outcomes. And most of the studies that we found were descriptive in nature, and not all of them had a lot of outcome measures. But this really sometimes is important to secure resources and funding to really offer adequate care and just to even keep things afloat. Experts did note that when evaluations were done or data collection was happening, there's sometimes a discrepancy between what hospitals, governments, and then the program or organization see as important for appropriate or important to collect. So sometimes there's this tension between what they want to collect, what they should collect, and what is the usefulness of that. And also limited funding and human resources can really impact and make it challenging to identify and track outcomes and data at the community or frontline levels. That's another thing that people have to do. And finally, the last one is to adopt sustainable and adaptive funding models. The academic studies that we reviewed lack detailed descriptions of funding schemes, but everyone noted the challenges with establishing program sustainability. And despite funding challenges, some programs have been able to deliver long-lasting services, although only few that we came across. And in these cases, we see that the organization received funding from mixed sources. And it is important to recognize that although these models of primary care are delivered at no cost, no direct cost for clients, accessing them again can be challenging in terms of different indirect costs to the user, going back to that framework of accessibility and the domain of affordability. So providing bus tokens to clients was a strategy noted to help reduce some of that indirect costs, as well as trying to scale up mobile clinics to really meet people where they are.
Thanks, Monica. I think we're going to wrap up and also just flag these two rapid reviews publicly available. We hope that you'll find them useful. We will put the URLs so you can track them down. The first one was published in 2022 and looks at international experiences and local experiences, and the more recent one highlighting initiatives in the province of Ontario. And so these are publicly available, and happy to share them if you have trouble getting them. But overall, we hope that we've sort of conveyed that there's a wide range of approaches out there, but there are some cross-cutting similarities and considerations to that draw learnings from all of these and where they're working well and how they can be potentially scaled up. But really, there's limited scale up. They're usually very local, small scale initiatives that kind of take their own shape and form with minimal oversight and kind of supports from governments or ministries of health, for example. And there's a huge gap in evaluations, and Monica already mentioned this, but there's a pressing need to demonstrate the impacts that these programs are having. They're filling a huge gap in our health and social supports in that are, available universally to all residents, but these innovative programs are often not even published. So we encountered some of them through the published literature, but others we heard more through talking to people and learning about the work that's going on, that's having impacts on people, and it's reducing hospital use, and it's improving health, reducing diseases, and improving quality of life. But they're not really well known, and these types of evaluations are really helpful to make that case for increasing investment. And I think I'll answer one of the questions now as I'm talking about sustaining investments. I see in the Q&A there was already a question around cost savings, because this is one of the ways that programs are being evaluated, is showing what are the potential cost savings through looking at diverted ED and hospital use. You can quantify and put an estimate of the total cost that would have been saved or diverted. And we didn't see any examples of where any costs are being redistributed. So these are hypothetical cost savings that are usually reported on versus anything that's actually redistributed to invest back in those interventions or communities or initiatives that we've talked about. That would be sort of a dream and wish of these groups, but I think that's a really great point that we saw in the Q&A already, and happy to hear more from Greg on that. But we wanted to end with also just a note that we hope that these considerations in terms of how we restructure and think through the reforms to the health system generally we think that these are useful, not just in serving the population experiencing homelessness, but generally across all high needs and complex populations with people with multi-morbidity and facing social and health challenges. And so we hope this has been of interest, and we look forward to hearing your questions. Thanks again, Susie, for the invitation to be here.
Thank you both very much. It was an interesting presentation. I'm just going to click through here. Whoops. So we have a bit of time for questions, as we mentioned. If you'd like, you can put your questions in the Q&A. But I thought I would just maybe start it off by asking one myself. So I was quite interested in what you were saying about the sustainability, and I was thinking about it a bit from kind of the public health perspective and wondering really what the role is for public health in terms of kind of supporting these type of initiatives. And I'm wondering if in particular there's a role around kind of the advocacy for them, and the advocacy for sustained funding from that kind of perspective. So I was wondering if you could speak to that a little bit, just about what the role for public health could be in these kind of collaborations.
Yeah, I think you answered the question already in terms of advocacy role, because that I think is a huge role that, regardless of where we sit and whether it's in public health authorities or elsewhere, that the just raising awareness and continuing to draw attention to these, both the problem side, but also the solutions are out there and known, and then we need to amplify that. And that's why we're doing, this through research and also through advocacy is definitely a great example, both locally, but also at a provincial and across Canada level. But importantly, the public health units and public health authorities are seen as essential partners in many of these initiatives. So we've heard, and we talked about the sort of multi-agency, multi-profession, and not just on a care delivery side, but also on who's providing the funding in kind and funding supports. So local public health units are involved in several of these initiatives where they're part of the sort of collaboration of agencies involved in organizing and coordinating the staffing and the monitoring for these. And so that's really promising because it shows how we can connect all these local players with the same, interests. And so local government and public health obviously are closely connected in Ontario. And so those were really clear in the province of Ontario. And I'm not aware of the examples across Canada, but I'm sure there are some, but that's one. And I don't know if Monica has anything to add, but it certainly came up in terms of being at the table when making decisions on how to support this population. And it helps when, public health units are already engaged in these discussions at the local level, which they very much are in Ontario.
That's great. I think, the kind of need for that integration became really apparent in COVID, and I'm hopeful that it's something that can kind of continue that, there is this real value to public health being more involved in that area. But Monica, did you have anything you wanted to add? Sorry, I couldn't see there.
Yeah, it's okay. Sarah covered it quite well. Susie, I think just to add to your last reflection, coming out of the pandemic, a lot of resources did really go into COVID-19 testing, treatment, and vaccinations. And as a result, a lot of other services had sort of been put on the back burner. And some of that includes, more broad like STI testing and harm reduction programs. So it'll just be interesting to see moving forward how those gaps are refilled.
Exactly. I'm just checking to see. Are there any other questions from the audience before? Oh, yeah, before I take up all the questions. We have one here from June. What percentage of initiatives were able to secure sustainable funding in Ontario, and what program characteristics or planning made that possible?
That's a tough one to answer, June, because as Monica said, we didn't compile a full, inventory of all the initiatives, so we can't give a percentage, but we can say that there were examples of sustainable funding, and it was usually either tied to funding for a community health center, like within community health centers in Ontario, there, it's a budget line item in the Ministry of Health, and through that broad, envelope, which is historically renewed each year. Then, for example, the Ottawa Community Health Center has been able to adapt and innovate in many of these sort of non-traditional ways in terms of providing care in shelters and mobile units and safe consumption sites as well. So that type of model is sustainable because it's embedded within an existing structure that is in place in the Ministry of Health budgets in Ontario. And the only other example that I can think of is where the funding envelope for doctors providing care within these mobile and non-traditional sort of supports for homeless population. There have been some efforts to negotiate salary, per diem kind of rates for the doctors who are providing these care. And then this is more sustainable, and it provides supports for the population for that, only the physicians themselves, not the other care workers who are necessarily part of the team, but at least covering the cost of physicians, because otherwise these there wouldn't be enough funds to maintain them within these models versus working in traditional fee-for-service or primary care practice. So there have been, I think that was within Hamilton that we heard that has worked, but that's an example that's in place in other initiatives as well. So there's a few exceptions, but those are the only ones that come to mind. I don't know if Monica has any to add.
Just to add, in terms of program characteristics or planning, some of the initiatives that we saw in Ontario that seem to, I wouldn't say necessarily be guaranteed sustainable funding, but seem to have more funding available in a longer time period than others. There was a lot of upfront planning across organizations, and really having evaluation plans set out front, to show sort of the value to have this funded, as well as logic models and things like that. So being very intentional with that up front seemed to make the case to help guarantee funding. And really it comes down to as well having multiple organizations and agencies at the table, so that you can sort of dig into different pots and types of funding as well.
Thank you both. Were there any other questions from the audience? Just, I guess I just had one more, which I was just wondering if you could expand a little bit on how some of these interventions can contribute to improving outcomes kind of at the population level. You spoke a bit about it, but I'm interested in hearing a little more about that.
Yeah, it's interesting. Like many of these initiatives are very small scale, right? So when you add them up in the collective, I think then we would be able to see the population level impacts. And we were hoping to actually do that work as a next step and a follow-up to this. So this was meant to be a kind of phase one where we look at Ontario specifically, the rapid review, the second one that we shared. Was meant to kind of uncover what the promising practices were in the province of Ontario, understand what their key characteristics are and what types of data they're collecting and how they're evaluating impact, and then aggregate from those, because then we could get the data from each of these initiatives, compile and make a data set, a secondary use data set that then we could estimate the overall population level impacts of these programs. And then what we were hoping to do is to simulate sort of how, if we were to invest more in some of these or scale them up or migrate, one model to another part of the province, what benefits that might yield to the health system on the one hand, and then population health to the other. So we weren't able to get the funding to continue with that work, but we would encourage anyone who's interested to reach out and to take that on, because I think that's where there's great potential and a huge kind of gap in our knowledge is that sort of population level impact. But there's definitely some, you can infer those types of benefits from those individual studies we presented.
Yeah, certainly. Yeah, it would be interesting to have that kind of information on kind of the broader scale. Also, partly in terms of just, again, making the case for these initiatives to be more sustainable and be better funded, right? It's another kind of information that can help make that case. But thank you both very much. I'm just going to check. I'm not seeing any other questions. So I'll just say again, thank you very much to both of you. We really appreciate you coming. It was a very interesting webinar, and I'm looking forward to reading the reports in more detail. For the audience, please do complete the short webinar evaluation when you leave. That you'll kind of get linked into the webinar's evaluation as you go. So a link to the slides will be emailed to everyone who's registered, and the recording will be posted online at nccid.ca. So you'll be able to see that. Oops, I'm just going to stop that. And we're also going to be having the final webinar in our series coming up on November 6th. And that one is going to be titled Anishinabekwe Gui Mano Bima Adzimi, Indigenous Women Will Live Well. And the focus on that is going to be looking at Indigenous women's experiences in shelters, how it relates to public health, and kind of the context of colonization and houselessness in Canada. So hopefully you can join us for that. It'll be November 6th from 11 to 12, and that's Central Time. Thank you everyone for joining us today. And thank you again, Sarah and Monica.
Thanks. Bye.
Bye.